can thiệp giảm đau trong các tổn thương xương khớp. Phần giới thiệu về CV của bác sĩ Huynh Su Kim này đã được giáo sư phó giáo sư Bùi Văn Giang giới thiệu từ đầu, và bây giờ cũng xin mời bác sĩ Huynh Su Kim trình bày bài báo cáo thứ hai.
My second lecture. It is about ablation of musculoskeletal lesions. There are several methods for managing the musculoskeletal tumors using percutaneous approach. Among those, thermal ablations are most commonly used, and I'm going to talk about radiofrequency ablation and cryoablation. RFA and cryotherapy are two most common methods used for thermal ablations. These treatments were initially used for curative treatment of liver tumors. Now, both options are widely used for various tumors arising from kidney, lung, and musculoskeletal structures. Radiofrequency ablation is performed using alternating current of high-frequency radio waves. These waves induce resistance of biologic tissue, which causes local ions in the tissue to vibrate. This results in heat generation, which ends in necrosis of tumor cells. Advantages of RFA over cryoablation are shorter ablation time and ability to perform tract ablation, which can prevent tumor seeding along the tract where needle has been inserted. Disadvantages of RFA include the fact that ablation zone cannot be visualized on CT during the procedure, and greater pain during and immediately after ablation compared with those of cryoablation. These are the equipments we use for the RFA. RF electrode is connected to the generator while performing RFA. The active tip can be adjusted depending on the tumor size, ranging from 0.5 to 3 cm. Target temperatures are set as 65 to 70 degrees Celsius for malignancy and 80 degrees Celsius for osteoid osteoma. Ablation time depends on the tumor size. Usually, ablation of the designated ablation zone usually lasts for less than 5 minutes. This is a case of 65-year-old man who was found to have metastatic chordoma adjacent to the left ischial spine. CT images were obtained and the corresponding lesion was identified. RF electrode was inserted within the lesion and RFA was performed. MRI obtained 3 months after the procedure shows disappearance of the previously noted lesion. Cryoablation utilizes a high-pressure argon gas for rapid cooling, which can reach -100 degrees Celsius within a few seconds. There are some advantages of this procedure over RFA. Ablation zone of cryoablation can be visualized on CT, which can be demonstrated as low attenuated area. Also, cryoablation is reported to be effective for both osteolytic and osteoblastic tumor. Pain after the procedure is reported to be less compared with that of RFA. These advantages include longer procedure time, which is due to multiple cycles of freezing and thawing of ice ball. Also, unlike RFA, ablation of the needle tract cannot be performed. Here's an example. This is a case of follicular thyroid carcinoma metastasis involving the right acetabulum. The metastatic lesion is seen as a discrete lesion on MRI and PET-CT. Cryoablation was performed using 2 needles inserted within the metastatic lesion. 2 cycles of freezing and thawing were repeated, which took 10 and 8 minutes each. It is much longer ablation time compared with that of RFA. The yellow arrowheads depict the ablation zone, which is seen as low attenuation. Now let me explain how the operation is performed. The patients are generally admitted the day before the RFA. MRI or ultrasound is performed to evaluate any change in size of the lesion if necessary. On the next day, RFA is done at CT room under general anesthesia. After the procedure, the patients are initially moved to post-anesthesia care unit and returns to the general ward. Patients are usually admitted for 1 or 2 days after the procedure for pain management and clinical evaluation of possible complication. There are a number of things to consider before performing the RFA depending on the location of the tumor. If the tumor is within the bone or deeply located, CT is used for imaging guidance. If the tumor is within the soft tissue structure, such as muscle that is superficially located, ultrasound is used for imaging guidance. In addition, as trabecular bone conducts heat less well than the muscle does, destroyed tumor volume is smaller in case of bone tumors. The most common indications of RFA for benign bone tumor is osteoid osteoma. Most patients with osteoid osteoma have a self-limiting pain which can be managed by oral medication. However, a subset of patients need more definite treatment. Since the first report in 1992 by Rosenthal, RFA has become the first-line treatment for these tumors. Equivalent success rates with decreased morbidity has been reported for RFA compared with those of surgical curettage. This is an actual case of RFA in osteoid osteoma. A 28-year-old man presented with right lower leg pain. The radiograph reveals periosteal new bone formation along the lateral shaft of the right tibia. CT reveals a radiolucent nidus surrounded by sclerotic lesion, which suggests the diagnosis of an osteoid osteoma. A track for the insertion of the needle was planned. Then the bone biopsy needle with drill were used to obtain tissue samples and to make a path to insert the RF electrode. We believe drilling across the tumor itself has certain therapeutic effect as it crushes the tumor tissue. Finally, the RF electrode was placed and RFA was performed. This is another case of osteoid osteoma. A 28-year-old female patient underwent hip MRI for evaluation of intractable left hip pain. She has been taking pain medication over a year. MRI reveals a small round lesion with peripheral high signal intensity centered at the medial cortex of the left femoral neck. CT was performed for further evaluation. CT images show the calcified nidus of an osteoid osteoma with surrounding sclerosis that might be attributed to new bone formation related to inflammatory reaction. RFA was performed under general anesthesia. After RFA, the patient suffered from severe pain related to procedure about 3 days. After 3 months later, the patient reported markedly improved pain and she stopped taking pain medication. In case of malignant tumors, there are 2 major indications for ablation. One is oligometastasis and the other is painful bone metastasis. Oligometastasis means presence of metastatic lesions in less than 5 separate sites. For these lesions, ablations are done to ablate the entire tumor to achieve local control. On the other hand, ablations done for painful bone metastasis that is intractable to radiation therapy targets the interface between the tumor and surrounding bone. This is a case of 69-year-old man who presented with recurrent myxoid liposarcoma in the left lower leg. The arrow indicates recurrent tumor located in the muscle. Ultrasound was used for imaging guidance of the RFA. You can see the recurrent tumor as a hypoechoic mass and the echogenic RF electrode inserted within the tumor. Follow-up MRI obtained after 18 months reveals no evidence of recurrent tumor. This is a case of RFA done for the metastatic renal cell carcinoma involving the tibia for pain palliation. RFA was done at the interface between the tumor and bone, which resulted a decrease of pain score. This is a case of renal cell carcinoma metastasis involving the left pelvic bone. CT-guided RFA with fluoroscopy-guided cement injection was performed, and partial pain improvement was achieved after the procedure. This is a case of 50-year-old male patient with multiple recurrent myxoid liposarcoma. He underwent numerous operations and radiation therapy at variable anatomic sites. His thigh MRI reveals intramuscular metastasis in quadriceps muscle. On ultrasound, the lesion could be visualized as an oval hypoechoic mass. RFA was performed under ultrasound guidance while placing the RF electrode at various locations to maximize the ovulation zone. MRI obtained 3 months after the RFA shows remaining peripheral enhancement in the lesion. We were not sure whether these enhancements were related to remaining tumor or benign condition. MRI obtained 10 months after the RFA shows increased size of enhancing lesion, which suggests local tumor recurrence. This recurrent tumor is actually larger than its initial presentation, and we can see how fast the recurrent tumor can progress in size over a short period. The patient preferred to undergo RFA rather than undergoing surgery as he thought it is less invasive. So we performed second RFA session for the lesion using ultrasound for guidance while placing the RF electrode in various locations. One thing I would like to point out is that RFA performing using ultrasound as an imaging guidance can be very challenging, as margin of the tumor as well as that of the ablation zone cannot be visualized clearly. It is also important to identify crucial anatomic structure in vicinity of the tumor as they can be damaged during ablation. A number of methods such as hydrodissection or air insulation can be used to protect these structures. This is a case of renal cell carcinoma metastasis involving the acetabulum. To protect obturator nerve and valve in the pelvic cavity, 5% dextrose water was injected through an additional needle inserted in the area. Thank you for listening, and I hope you enjoyed my lecture. Thank you very much.